Hello, everyone. Welcome to today's session on primary biliary cholangitis. My name is Paula Neves, and I'm the lead for the Center for Living Organ Donation. We have a great hour packed with lots of information for you and three amazing speakers. Our first speaker is Dr. Aliya Ghulam Hussain, who is an assistant professor at the University of Toronto and a clinical investigator with the Toronto Centre for Liver Disease at Toronto General Hospital. We're also very, very fortunate to be joined today by Kate Curvan, who lives with PBC and received a living donor liver transplant, and Jackie Curvan, who is a living liver donor. They will be sharing their stories later on in this session. We welcome your questions as we go through the following three presentations. You may submit them on slido.com, and the event code is PBC-liver. That's PBC-liver. And I would now like to invite Dr. Aliya Ghulam Hussain to take us through her presentation on primary biliary cholangitis. Dr. Ghulam Hussain.
Thank you very much for the opportunity to speak today. Like Paula said, the focus of our presentation today will be primary biliary cholangitis, and this is a topic that's near and dear to my heart. It's part of the majority of my clinical practice and research efforts. So we'll talk a little bit about, as we go through, about the disease itself, why it happens, treatment approaches, and the role of liver transplant in management of this disease. The next slide. So what is PBC and what does primary biliary cholangitis mean? So if you break down the word, primary means an intrinsic liver disease, i.e. it's not caused by a secondary cause or an additional cause, it's intrinsic to the liver. Biliary means the bile duct. So you can see in the top left corner, the liver lives in the right upper quadrant of the body. So if you think about sort of I sort of think about a tic-tac-toe box, and the liver sits in the top right corner. And if you look at what the bile ducts look like, if you sort of cut the liver in a slice, you'll see that these green tubes are what bile ducts are. And bilirubin is a compound that's made inside the liver cells, and what it's supposed to do is be secreted into these bile ducts, which are these green tubes that ultimately are supposed to be, ultimately the bilirubin travels from these green tubes into the gut, where it's then excreted through the bowels. What happens in PBC is, if you look at the top right corner, those green bile ducts become inflamed, and the immune system starts to react against those bile ducts that sit within the liver. And that leads to many of the manifestations of liver disease in PBC. Next slide. So what exactly is PBC? Previously, PBC was called primary biliary cirrhosis, and it's in fact through the efforts of patient organizations that the name was changed, because not everybody with PBC has cirrhosis. And so the C in the name was changed to cholangitis, which means inflammation of the bile ducts within the liver. And sometimes this is helpful. I think this was a very good name change for patients and for providers broadly, but it can get a little bit confusing because there's many different liver diseases with similar acronyms, but it's very different from another bile duct condition called primary sclerosing cholangitis, or PSC. And so it's important to make that distinction clinically and for patients, because prognosis is very different. But ultimately, PBC is just one of a family of autoimmune liver diseases that we sort of group together. They're very distinct in how they're managed and what the prognosis is, but they sort of, they're all what we call immune mediated. So that is a family of conditions called PBC. Then there's autoimmune hepatitis and primary sclerosing cholangitis. Next slide. So patients often ask, why does this happen? Not only for PBC, but for any chronic condition that they might have. So why do you get PBC? And it's a sort of frustrating answer because we don't exactly know exactly why it happens. We know several triggers that could be associated with disease development, but ultimately the pathogenesis, while we've learned a lot in the last sort of 10 years or so, it's not entirely understood. But what we do know is that PBC is the result of an immune reaction against the bile ducts, and essentially it's an antibody attack against the bile ducts that live in the liver. Next slide. Why does it happen? Again, it's not just one thing that triggers disease, particularly in immune-mediated conditions. There's often multiple factors that contribute. And so we sort of think about this Swiss cheese model of disease development, where there's a genetic predisposition and an environmental trigger, and probably many other things along the way, and many other triggers along the way, that once those holes within the Swiss cheese line up, disease develops. But having any one risk factor is probably not enough. And what those environmental triggers are, I mean, I wish we knew that there was one specifically, but several have been hypothesized, including urinary tract infections, estrogen components like hormone replacement therapy, past smoking, and exposures, environmental exposures, such as living adjacent to toxic waste sites. A lot of that data is from Europe and from the UK in specific, but there is some evidence to say that exposure to toxic waste sites might be a contributing environmental trigger. And the hormonal hypotheses are interesting, and even the urinary tract infections are interesting, because we know that PBC develops more in women than in men. And those things are certainly more common in women. Next slide. The genetics of PBC are very interesting. So this has become a lot more, we've learned a lot more about this over the course of the last, say, 10 years now. And we've identified many genes that are associated with disease development. And interestingly, a lot of those genes that we've determined to be associated with PBC are not just specific to PBC. They also occur in other autoimmune conditions. And that's why autoimmunity, you'll note that if you have an autoimmune condition, or someone you know has an autoimmune condition, there's a higher risk for them to have an associated or a different autoimmune condition. And it's because these genes are not necessarily disease specific, but likely predispose people to autoimmune conditions in general. So it's not infrequent that we see patients with PBC have other conditions like celiac disease or rheumatoid arthritis, lupus, or psoriasis. Next slide. And the environmental trigger is thought to be important in the setting of a genetically susceptible host. So remember, I'll say that there is no specific gene that we can test for that would be associated with PBC, but it's likely that when the genetic risk lines up with an environmental trigger, that's when disease could develop. Next slide. So how does PBC present? I mean, there's a wide range of presentations, and I think over the course of years, we've become a little bit more in tune to the diagnosis. The diagnosis of PBC is based on a very specific autoantibody in the blood. And as people have become more aware of the disease, an incidental diagnosis is much more common. And what does that mean? It means that patients will go to get their blood test done, and they'll be noted to have an asymptomatic elevation in their liver tests, and then their primary care doctor, their gastroenterologist, or whoever they're seeing may check for this disease-specific anti-mitochondrial antibody, and once that is noted to be positive, the diagnosis can be made. So it's not infrequent that patients have no symptoms at all, but symptomatic disease does certainly happen, and there's a variety of symptoms that can be associated with disease. I've listed some of the most common ones, including fatigue, which can happen for many, many reasons, of course, but is reported in PBC in up to 78% of patients. And what they usually describe is not like fatigue, like I want to sleep, but fatigue like I'm drained, like there's no juice in my battery. And so it's just kind of a type of fatigue that can be really debilitating and impact quality of life. Pruritus or itching can be a common symptom as well. It varies in prevalence from anywhere from 20% to 70%. Oftentimes there's no rash associated with it, and there's some triggers that can make it worse. Dry eyes and dry mouth, which is called Sika syndrome, often happens as well. And then metabolic bone disease, particularly things like osteopenia and osteoporosis, are also common symptoms. And those can happen in early and advanced disease. As disease progresses, you can get symptoms of liver dysfunction or liver failure, which include things like jaundice or yellowing of the eyes or of the skin. Fluid retention like swelling in the legs or in the abdomen, known as ascites, or bleeding through the bowels from veins or varices that could be associated with high pressures in the blood vessels around the liver. Next slide. So how do we manage symptoms? I always tell my patients, and I tell fellows that come through the clinic, that we have to think about PBC and management in two separate ways. We think about symptom burden and managing symptom burden effectively, because that truly impacts patient quality of life. And then you think about how you're going to manage the disease. And sometimes those things overlap, but sometimes they don't. And this is just an algorithm that we think about using with the students and fellows in our clinic about the symptoms that patients get. And you'll see that on the right side, this is the approach to managing itch. There's a stepwise approach to medicines that you use that can help itching in patients with PBC. Unfortunately, none or few of these agents actually help the disease. And that's why it's important to think about both components when you're managing patients. Fatigue, unfortunately, has no medicines that will provide immediate benefit for fatigue. So most of it is managed symptomatically and by making sure that there's no other agents, other reasons patients are having fatigue. And then Sika syndrome is managed with topical agents. Next slide. And what we've done in the clinic here is we've started sort of in the clinic here and actually across the nation is sort of tried to collect data from patients with PBC across the country. And one of the reasons we want to do this is to understand whether there's differences in patient presentation across the country, but also in different ethnic minorities. And this is work that was done by one of our PhD students that shows that symptom burden can be different based on ethnicity. So if you look at the bar graph on the left, you see patients who have an indigenous background tend to have highly symptomatic disease, whereas other patients such as Black Canadians or African Canadians may have less symptom burden than other ethnic backgrounds. And this is just data that's collected from patients' report, so it's not perfect, but it's certainly very interesting. And the sort of pentagons that you can see on the right just show the magnitude of each of the individual symptom complexes in these ethnic minorities. Next slide. And when you overlap them, you can see the different you can see the magnitude of differences with ethnic minorities. And that is really important for clinicians to identify and to recognize and to make sure that we're addressing these issues in the clinic. Next slide. So I talked about treatment of symptoms, and that's one component of the disease, like I told you, and it's important for clinicians and patients to bring those things up and us to manage them. But treatment is treatment of the disease itself is a different sort of part of management. And until May of 2017, at least in Canada, there was only really one agent that we could use to help PBC disease, and that is called ursodeoxycholic acid, or UDCA, and that was approved in 1994. And to be honest, between 1994 and very recently, once a patient was diagnosed with PBC, you would treat them with urso, and there was nothing really else to offer to delay disease progression. And how urso works is we don't understand entirely, but it's a synthetic bile acid that generally is thought to sort of flush out toxic bile acids and replace them with healthy bile acids. Next slide. And we use URSO and we rely on URSO because it works, and it works really, really well. So it's very important for patients with PBC to be on therapy. And this just shows the biochemical improvement or the blood test improvement in patients with PBC treated with URSO. So you can see the curves start high. All of the blood tests are high initially at before therapy. And then once you start URSO, the blood tests improve. Markers of biochemical inflammation or markers of inflammation in the liver, namely things called the alkaline phosphatase, the AST, and the serum bilirubin. And so we know that it's important to use URSO because we see the biochemical benefit. Next slide. Next. And how we assess response to therapy is how well the alkaline phosphatase in particular responds to therapy with URSO. So patients are diagnosed, they're treated with URSO, and then we look at the response, their blood tests after about a year of therapy. And if that alkaline phosphatase level decreases sufficiently to a level of about 1.67 times the upper limit of normal, that's generally thought to be a sufficient response, and patients who have a response should do pretty well. Next slide. Next. So this shows that patients on the left side are patients who are responders. So those patients who are treated with URSO and their blood tests improve significantly to that threshold of 1.67 times the upper limit of normal, generally do as well as the general population. So once you treat patients, you can be confident that if they've responded, prognosis in the large minority is very good. But there's still an important group of patients who don't respond perfectly well to URSO, and that's the curve on the right. So these survival curves, you can see the one on the top that says standardized population, are those people in the general population. That's what mortality is. And the curve in the middle is patients with PBC who don't respond perfectly well to URSO, i.e. their liver tests remain elevated despite therapy. And those are the ones that we really wanted to focus on as new drugs became available, because 40% of patients with PBC won't respond perfectly well to URSO and needed something else to prevent them from progression. Next slide. So this is work that was done by an international consortium called the Global PBC Study Group that looked at what markers can we use to identify patients who are going to run into trouble and might need to be considered for transplant. And what they found is that an alkaline phosphatase or an ALP level of more than 2 times the upper limit of normal, or a bilirubin level that was abnormal after 1 year of therapy with URSO, are the patients that are at risk of progressing to a poor outcome. So this was really important for clinicians and for patients alike to identify those who are at highest risk, and for for pharmaceutical companies and regulatory agencies to say that if these numbers improve, maybe we'll be able to improve outcomes in these patients. Next slide. So risk assessment in the clinic is really, really, really important, because we need to know as clinicians, and patients need to know, who are those at risk of progressing to require transplant. And so there's a few things. Before we had other drugs, we would only use URSO, and so risk assessment wasn't as important. But now, as new drugs are becoming more available, we have to be able to identify patients who are most at risk. And I teach the fellows, and I tell patients too, that we think about many different things, but 3 things primarily. Number 1 is, when were you diagnosed? If you were diagnosed with PBC when you were less than 50 years old, that means that you have to live with this disease for a really long time, and your risk of progression over the course of a lifetime is higher. So age younger than 50 at diagnosis is important to me. Biochemistry, so how well did you respond to ursodeoxycholic acid therapy? That threshold of 1.67 times the upper limit of normal. Are the blood tests still elevated on treatment? And if they are, that is a risk of progression. And then how much scarring is in the liver? Because a scarred liver is often a functional liver, but scarring progresses over time. And that can lead to development of complications, the things like liver failure that I was talking about before, jaundice, fluid retention, etc. Next slide. So what we know is that URSO on its own, when it's the only drug you have, it's what you use. But we know that URSO slows down the disease, but it does not stop the disease. So having additional agents or other therapeutic options was really, really important. And this just shows that the survival curves on the left show that in patients who are treated with URSO, whether or not they have a full response, they benefit from therapy. So they should always continue on ursodeoxycholic acid therapy, even if their numbers stay elevated. And the bar graph on the right just shows the age point, meaning patients who are younger at diagnosis have a higher risk of coming to transplant, primarily because they have to live with disease for a long time and inflammation, whether it be overt or even subclinical inflammation. Next slide. And this shows that scarring or degree of fibrosis in the liver is important. So whether you have a biopsy or whether fibrosis levels are assessed in other ways, the degree of fibrosis in the liver is associated with a risk of progression to transplant. So the curve on the right, you can see the blue line shows patients with minimal fibrosis or early fibrosis, and the red curve represents those with advanced fibrosis. And the lower the curve is, the lower the transplant-free survival, i.e. the higher risk of coming to transplant. Next slide. And biopsies are not done in everybody with PBC. In fact, they're done in the minority of patients with PBC, probably less than 5% of patients in our program. But there's lots of different ways to measure scarring of the liver. So understanding how much scarring in the liver is there is important. And high degrees of scarring, whether it's measured by liver stiffness or biopsy, is associated with worse outcomes. Next slide. And so once you've identified patients at risk of poor outcomes, like I was saying, we had URSO alone, but more recently there's many other agents. It's a really exciting time to be in the therapeutic landscape for patients with PBC, because there are many other agents that are in the development pipeline and a few that are used clinically. So this was a paper that was published in the New England Journal of Medicine. I love to use these examples because there's very few times in the world or in medical history where autoimmune liver diseases end up in the New England Journal of Medicine, but this was one of them. And this used an agent called obeticholic acid in patients with PBC who did not respond perfectly well to URSO. Next slide. Next, one more, I think. Oh, sorry, go back one. My mistake. Yeah. So this is the data from that study that showed that obeticholic acid was associated with further improvement in blood tests when you added on to ursodeoxycholic acid. So the pink bars are patients who were just treated with URSO, and the blue and purple bars are those who were treated with ursodeoxycholic acid plus obeticholic acid. And you can see the patients with response were much higher in patients who were treated with both agents. So about 50% of patients who were treated with both agents had a reduction in their alkaline phosphatase to that threshold we talked about, 1.67 times the upper limit of normal. And this was the first time we had another drug that was showing this biochemical improvement so consistently. Next slide. And that response, now we're accumulating more and more data, is durable. So not only was it in the study for 12 months, but we're seeing that extend out to 24 months, 36 months, 48 months, and even 72 months, which is important. You don't want a drug just to work for a month or two or even a year or two. You want it, especially in a chronic disease, to work long term. Next slide. Next. And so clinical trials are really an important part of the drug development pipeline, but they're not the only thing, right? Patients who enroll in clinical trials are not oftentimes reflective of the general population. So seeing what happens in the real world is really important. And this is data, sorry, this keeps repeating, but this is data that we accumulated through this CANAL program, which is the data set that we're collecting from patients all over the country, that showed that even not only in clinical trials, but even in patients treated with obeticholic acid in the real world, their blood tests improve when you add obeticholic acid onto ursodeoxycholic acid. So this gives patients confidence that they might benefit from new therapies. It gives clinicians confidence that patients with PBC might benefit from new therapies. And I think this sort of data is really important to move the field forward. Next slide. So So obeticholic acid is the only licensed therapy that the regulatory agencies in Canada and the US and in Europe have approved to add on to ursodeoxycholic acid therapy, but there are other agents that are available. One is called bezafibrate, which is an agent that is used to treat cholesterol in many patients who don't have PBC, but was also noted to improve liver tests in patients with PBC. So this was studied in, again, this New England Journal of Medicine paper, and showed that bezafibrate, when you add it on to ursodeoxycholic acid therapy, is associated with an improvement in liver tests. And if you look at the bar graph on the right, you'll see after 2 years of therapy, 31% of patients had normalization of the liver tests after they were treated with bezafibrate. Next slide. And there's even data to suggest that maybe adding urso and obeticholic acid and bezafibrate together can improve liver numbers further, because the goal, we know, is that alkaline phosphatase and bilirubin, the lower they are, the better patients do. And so sometimes that means adding on therapies, which is not easy for patients, for sure. Adding on medicines that you take long-term is not an easy thing, but the goal is to try to improve outcomes and prevent things like liver transplant. And so this was a study that looked at adding on, or triple therapy, adding on bezafibrate to obeticholic acid. And this did show that that improved blood tests further. Next slide. Other agents are also being studied too. So this agent is called seladelpar, which is a PPAR delta agonist. And this was a clinical trial that was really exciting for clinicians and I think patients too, that showed that using this drug, and it's still in clinical trial, so it's not available commercially, certainly just yet at all. But this agent was associated not only with improvements in blood tests, but also improvements in symptoms like itching. So remember earlier on, I said that we treat the disease and then we treat the symptoms, and sometimes and oftentimes those medicines don't overlap, but perhaps there are agents that are coming through the pipeline that are able to treat both components of disease, which is of course very important for patients. Next slide. So what about transplant in patients with PBC? So when we think about liver transplant in general, there's a prioritization system that relies on a score called the Meld Score. So the Meld Score is MELD. The way I explain it to patients is that's a score that goes from 6 to 40 or 5 to 40. 5 or 6 means your liver numbers are normal. 40 means that you're at the top of the liver transplant waiting list. And we know that patients derive benefit from liver transplant when their score hits about 15. So a score of 15 or 15 is the threshold at which point we say that this patient might benefit from liver transplant. And that's when we send a referral to the transplant program. And that's independent of disease. But we know in patients with bile duct disease like PBC, the Meld score is not perfect because it generally doesn't reach 40. Sometimes it does, but one of the problems with transplant, as I'm sure this audience will know, is that there are far more patients that need transplants than there are organs available. And that's one of the beauties of living donor liver transplant. So while a patient might need a transplant when their Meld score is 15, they oftentimes won't get access to deceased donor liver transplants until their Meld score is 30 or more. And so that waiting period is a waiting period of being ill, having symptoms, and not being able to access a treatment that you know is necessary and will help. So a Meld score of greater than 15 is an indication to consider liver transplant in patients with PBC. There are other things that we can consider, like liver cancers, significant itching or refractory itching, and other complications of liver disease like pulmonary manifestations. I've bolded chronic fatigue because while that can be significantly burdensome to patients, it sometimes doesn't get better post-transplant. And so that's an indication that's an indication that we think about a little bit more carefully when we're thinking about a liver transplant referral, because we want patients to feel better after transplant. And sometimes that component doesn't always go away. Next slide. What's encouraging to us is that if you look at data in the UK and the US over time, it does seem that that therapy for PBC works in terms of not only improving blood tests. I tell patients this and I tell fellows this all the time, that we don't treat blood tests, we don't treat scans, we don't treat things that we see on the computer, we treat people, right? And people, what's important to patients is that their outcomes are better, right? And so identifying data like this that say that listings per million patients over the course of time in PBC is declining over time. And why is this? Well, it's because, see, the curve started at 1994, which is when URSO was approved. So with medicines that are effective, while they may not always be easy to take, and there may be side effects, and adding on therapy is not always easy, we know that they are impactful in terms of decreasing liver transplant and progressive liver disease, which is really, really an important outcome. Next slide. But we also know that these are uncommon diseases. So this family of autoimmune conditions I mentioned, PBC, PSC, and autoimmune hepatitis, despite being rare or uncommon at least, they occupy a disproportionate need for liver transplant. So there's far more patients than you would expect on a liver transplant waiting list, or who get liver transplants with these underlying conditions than there should be, which tells us that there is still work to do. Next slide. And this is data from UNOS, which is the American transplant data set, that looked at what is the Meld score. Remember, I told you that Meld score is used for prioritization of liver transplant. What is the Meld score in patients with PBC who get transplanted with deceased donor liver transplants versus living donor liver transplants? And remember, I said that living donation is a beautiful gift. It is it's one of the parts of my job that I love most, because you see its impact on patients who may have a low Meld score and can't get access to a deceased donor because their Meld score is just not high enough. They're not, quote unquote, sick enough based on their blood tests, but feel sick enough to require transplant. And you'll see that the Meld score in patients who get a deceased donor liver transplant, and again, this is in the US, not in Canada, is on average 21 plus or minus 9, whereas in living donor liver transplant, the average Meld score is 14. So you can see patients get access to liver transplant with a score that's much lower, which also means that they're clinically probably more well and go into transplant more healthy, well, and so come out of transplant more well. Next slide. Next. So this just looks at the time that patients wait on the liver transplant waiting list when you look at deceased donation versus living donation. And you'll see that there's a significant difference. Again, this is US data, it's not Canadian data, but if you look at the columns that say time to DDLT, or time to deceased donor liver transplant, and time to LDLT, or living donor liver transplant, it's 8 months, median of 8 months, but a big range that can go up from 8 months to 2 years. But with living donor liver transplant, that time frame is reduced significantly because it ultimately ends up being an elective procedure. So 3 months versus a median of 8 months, which is pretty impactful for patients. Next slide. Next. And this shows the likelihood of patients getting a deceased donor versus a living donor in PBC. So the hazard ratio you can see or the odds ratio for patients with PBC to get a deceased donor liver transplant is low. So what happens is many more patients with PBC and cholestatic liver diseases to get access to transplant efficiently, quickly, and more predictably, they have to, or they're forced to sort of look at the living donor liver transplant route, just because, like I said, that Meld score doesn't really get high enough fast enough for them to be able to attract a living donor. And so for them to be able to attract a deceased donor. And so living donation is really, really it's a resource that is invaluable to these patients. Next slide. Next. And what's exciting, oh, sorry, back one, please. What's really exciting is not only is the incidence of transplant improving over time, but the outcomes in transplant in patients with PBC are really excellent. So you can see that these two curves look at patient survival and graft survival over time, and you can see they stay pretty darn high. And so what we know is whether there's deceased donation or living donation, patients with PBC who get transplanted tend to do very, very well. And it's really, in the right setting, a really life-changing and life-saving intervention. Next slide. So I'm a little bit over, but in summary, I just wanted to say that PBC, I hope you learned something, but PBC is an uncommon chronic cholestatic liver disease. Certainly not everyone with PBC has cirrhosis, and we don't refer to it as primary biliary cirrhosis anymore. The presentation of disease is variable and can range from having no symptoms at all to having very advanced symptoms. Common things include fatigue, itching, and dryness or Sicca syndrome. Treatment with ursodeoxycholic acid is really, really important for everybody with PBC, but there are newer agents that are available that can reduce the need for liver transplant in the right patient. Transplant, whether it be living donation or deceased donation, is really an excellent second chance at life, really, for patients that need it. And living donor liver transplant particularly offers really timely access for those in need. And that's it.
Thank you very much, Dr. Ghulam Hussain. This was a really important presentation, and I know that many in the audience will have additional questions based on what you presented. We're also very fortunate today to be joined by Kate Curvan and Jackie Curvan, who will tell us a little bit about their experience with PBC and living donation and transplantation. So I'll turn it over to Kate first, and then Jackie, and then we'll come back to questions from our audience. Kate?
Okay, great. Thank you so much. I'm really happy to be here to share my story. I know Jackie and I took advantage of all the resources that your office and Toronto General Hospital provide for people going through this process. So we're really happy to be able to give back today and to share our story. So my name is Kate. I've had PBC for 20 years, and I'm right now 6 months post-transplant. My journey began in 2001. I just had a routine blood test done by my family doctor, and it showed that I had elevated liver enzymes. And I was surprised at the time. I felt healthy. I had no symptoms. And it turned out that I had PBC, and a few months later, when I was referred to a hepatologist, they did a biopsy, and they determined that I was in stage 3-4. So not only did I have this new disease that I knew nothing about, but I also had damage had already happened, and I had an advanced prognosis. So that was a lot to handle when I look back on that. But I was lucky. I was an URSO responder. So for the next number of years, I lived a fairly normal life on URSO. I got married. I had 2 beautiful girls. They're in the picture, Stella and Kira. And I was doing quite well. It was just within the last 5 years, I didn't respond as well to URSO anymore. So I enrolled in the clinical trial that you heard about for Ocaliva. And I ended up taking that drug along with URSO once it was approved by Health Canada. But at this point, I'd already had a lot of liver damage, and I started to become symptomatic, and I had more fatigue, I had itching, I developed portal hypertension. I had a varices bleed that hospitalized me for a week and had developed ascites. So things were progressing, and my quality of life was diminishing. And I just wasn't able to do the things that I was able to do before, and to spend time with my family. So I think it was probably late February, early March, when I was told that I needed a transplant, that it had got to that point. And I was listed for transplant. But as you heard in the presentation, so my Meld Score, I was told, was too low for a deceased donor, and that my best option was a living donor. So of course, this has to happen right when the country is shutting down because of COVID. And, we have all this uncertainty in front of us with, being listed on transplant, as well as having to deal with, all the scariness associated with the pandemic. So first of all, I had to kind of come to terms with the fact that this is where I was. And my husband thought that, maybe he would step forward and try to be the donor. But our blood types weren't compatible, so he was immediately told that he wouldn't be able to do that. So then we had to turn to my family. I'm very lucky that I have a large, loving family, and they were prepared to step forward in a situation, which is something I'll never forget. And so my sister first stepped forward, and she went through all the testing, and I think we found out late May that she wasn't compatible, and she couldn't be my donor. So then Jackie, who you're going to hear from in a few minutes, stepped forward, and we found out, I think it was probably early August, when she called me. And I can just remember the emotion when she called me to say, not only was she a match, but she was eager and prepared to go ahead with the surgery. And just incredible emotion. I remember at the time, just when I think about it, and, what a huge sacrifice and what a huge thing to do for somebody. And I also remember thinking, wow, this is something that I knew that I was progressing towards, but now is actually happening. We're actually going to get a date, and this was going to proceed. So I turned to a friend of mine, Gail Wright. She's the president of the PBC Society. And I said to her, it would be really helpful for me if you know anybody who has actually gone through this process who I could speak to. And she got me in touch with a couple of people. And this is something I found probably the most valuable advice I could provide. Talking to these people, one of them I'm still in touch with, and she's now 5 years post-transplant. And they just provided me so much personal information about what to expect, what the stay in the hospital would be like, what the recovery would be like. And they told me the good, the bad, all of it. So I could fully prepare myself and prepare my family for what was about to happen. And it was also hopeful, because I heard their stories, and I heard that they're on the other side and how well they were doing. And as I said, one of them was 5 years post-transplant and doing well. So to me, that was a really important thing to be able to do. So once we got the surgery date, we were also faced with COVID, which I know is a lot of you are facing right now with us still being, fully in COVID time. So we were told that there's restrictions, and that Jackie and I could have only one family member to visit, and it was very limited when they could come and see us and things like that. So I remember that was hard, because I thought, I have this wonderful family who's here to support me, but I have to go on this journey, somewhat by myself. And I remember when my husband and my two girls dropped me off at the hospital, I had to show up the day before because I had to do extra testing and a COVID test, and I had to go into the hospital by myself and start the journey. And I just remember how hard that was, and how difficult it was for my family and for my kids, because I didn't know, would I see them in a couple of weeks? How long would it be? So that was definitely something that was challenging. But I have to say, once I got into the hospital, all the nurses, the doctors, the staff, everyone are so supportive, and they understand, we're in a difficult time right now. COVID's restricting what we can do and who can visit. And they were really, really, really supportive. And I definitely want to emphasize that. I know the night before my surgery, my surgeon, Dr. Ganeker, who's an amazing person, an amazing surgeon, came by to see me. And I said to him, it's really important to me for my husband to hear all about the surgery and what to expect as well. And he said, no problem, let's get him on the phone so we can all talk and we can ask questions and all be really comfortable with what's about to happen. And that was really key for me. And I found through my whole stay at the hospital, if there was information that I thought was important for my husband to hear as well, they were more than happy to have him on the phone, FaceTime, whatever it was. They definitely made him part of the process if he couldn't be there all the time. So, I made it through the surgery. And when I look back at that time, I think of, when those first couple of days were hard, but I felt so much better than I had for the years leading up to the surgery. And I realized for the first time that I wasn't itchy. And I was one of those people that was itchy all the time. And I just couldn't believe that all of a sudden my body felt so different and I was no longer itching, and I felt hungry again, and because I had lost weight prior to surgery, and things. So it was incredible. And there was also challenges, of course. I found out 4 days post-transplant that I had a possible rejection. And that was really hard to hear, because I thought, here, my sister-in-law has gone through this huge surgery and done all this for me. And now I'm possibly rejecting the liver that she's given me. So that was hard. But, Toronto General is an amazing place. They've done this so many times. And I knew that I was in good hands and that it would be okay. And I'm 6 months, as I said, and my liver is great and everything worked out. So there's challenges for sure. I went home at day 10. So one of the pictures up is me with my girls when I came home. So I was 10 days in the hospital, came home and started my recovery. And, it's been okay. Like, you take it each day as it comes. You need support at the beginning to kind of get through that first little bit, but you do get stronger, and it's it's hard. I mean, I definitely was scared going into this, but I feel so different on the other side. I feel better. I'm getting stronger, and I'm so glad I went through it. So in summary, like if I had to give any advice, I would tell people that if you can speak to someone and kind of get their personal experience, I think that's really valuable, and it really gives you a really good understanding of what to expect, and it helps you plan for what it will be like when you get home and with your family. And for all those living donors who are listening, you guys are our heroes. Sorry, I definitely wouldn't be here if it wasn't for Jackie. And I'll always remember that. And it's something that, something I'll always cherish, and something we'll share forever. Thanks.
Thank you very much, Kate. And I'll turn it over to Jackie.
Oh, okay. Thanks, Paula. I'm Jackie Curvin, Kate's sister-in-law. Yeah, this has been quite a journey, and I really appreciate being here and having heard everyone speak. I always learn something more as I go along. So like Kate said, just as I was sort of entering the family, Kate was diagnosed with her disease. And for a long time, for many years, Kate was doing really well, and you would never know that there was anything wrong. And about 5 years ago, we spend a lot of time up at the cottage in the summers. You started to see some changes, and we have it, you can see in my picture, I have 3 children, and 2 of them are around the same age as Kate's girls. And you could see Kate just not able to do as much as she was before. We go on bike rides, go to the beach. She was often very tired, and we just every summer would see less of Kate. She didn't feel well, and that was really hard to watch because she was so active, and to see her feeling that way, it broke my heart. As a mom, I wanted her to be a part of everything. So when the opportunity arose to be a living donor, I didn't hesitate. I had the chance and I took it, and I'm so glad I did, because to see Kate today, it's phenomenal. So I'm a bit emotional. I always get like this when I hear Kate talk, especially, but I'll do my best to keep going. So the application was accepted, and like Kate said, it was all during COVID. So I met with a lot of the team virtually. I had some consults to make sure that, this is what I wanted to do. Everyone was fabulous. I got to meet Dr. Cottrell, and like Kate said, the surgeons had all the time in the world for us, answering every and any question that we had. I did go to Toronto for 2 days for actual testing to make sure I was a good, suitable match, and then found out that I was a match, and it was wonderful. Very exciting to find that out, and like Kate said, very emotional. It was never a big decision for me, but it was a big, I want to say it was a big decision in the sense that our whole family was involved. And so we wanted to make sure that we were prepared. And so when we got the surgery date booked, it was important that we knew what was going to happen. So Kate and I did access a lot of the videos that are provided, and we watched them. And with my family, it was great because I knew sort of what was going to happen with me, what I might look like, especially with my youngest. As you can see in the one picture, I didn't look like myself. I was still happy. I was thrilled that everything was a success, but I looked different. I went into the hospital feeling pretty good, and I left feeling not so awesome, which I'll touch base a little bit about. When the surgery was booked for September 16th, Kate had already been in for the 1 day, and I got to the hospital the following morning, and it was fantastic. I mean, as Kate said, we could only have one family member with us, but everybody there, whether it was a surgeon, a nurse, whomever, I mean, everyone was so kind and so appreciative. I felt very comfortable. I got prepped right away. I wasn't waiting around very long. I was in the surgery room, operating room, probably within an hour of being there, it felt like. And I woke up on the flip side, and Colin was able to be in there. Then I remember the nurse going to get him, and we just waited it out together until we found out that Kate was okay. It was remarkable. I remember there was a picture there of me in the yellow robe. Because of COVID, Kate and I couldn't see a lot of each other in the hospital. And if I did want to see Kate, I had to robe up. And because I was a bit fragile when I woke up, a bit out of sorts. I didn't like wearing the robe. So Kate and I didn't get to see each other too much. But I do remember asking her, "Are you still itchy?" And that was my first thing. I thought that would be horrible to live with. And she said, "I don't itch anymore." And I remember feeling so excited. When I did wake up, I didn't feel great. As the medicine and everything started going through, I had never had major surgery. And I remember reflecting and thinking, this is how Kate has felt for 5 years. It was a lot of perspective for me. I had gone in healthy, like I said, and now I felt horrible. And Kate, sort of on the other side, had gone in feeling horrible and was feeling relatively better. And it was really awesome. That got me through a lot of it. I was only in the hospital for 7 days, and they taught me really I had to do the only sort of after care for myself. I had some medicine that I had to take. I was pretty much off of my meds by the time I left the hospital, and I had to take injections for blood thinners for 5 weeks following. I didn't have an appetite for a really long time. I know Kate jokes she had the appetite, which I had when I entered. I lost my appetite, but it did come back. I slept a lot. That was that my body was healing, and it healed very quickly. And Kate gave me good advice that she had gotten through some of her supports. And the advice was, I wrote it down because it was, if you're not having a good day, tomorrow will be better. And I kept thinking about that every day. And I was also told, don't gauge your progress by one day, look at it every week. And it was true. Every week I felt remarkably more like myself. I did have the luxury of taking the full 3 months off, and I took it. I'm a kindergarten teacher, so I wanted to make sure I was ready to go for that new adventure. So the 3 months, I can truly say, was ample time for my body to heal. I was better than myself after 3 months. The first month was probably the hardest, because I had the needles. That was something new for me, and no appetite. So I was weak and tired. But once my appetite started coming back, really, they choose us as candidates because we are healthy, and they know we'll recover quickly. And it's amazing what the surgeons can do to improve someone's life.
Thank you very much, Jackie. We have a couple of minutes for questions submitted through Slido, and we'll just show those in a moment. We do these webinars on a regular basis, and I never cease to, get emotional when I hear patient stories, living donor stories. It is, life-changing. It is life-changing, and we really appreciate you taking the time to share your story with us today. Dr. Ghulam Hussain, a lot of the questions that were received relate to, the clinical management of the disease. You see some of those up on the screen, and because of our very limited time, I'm wondering if you could address in general some of the things that you may not have had a chance to address during your presentation or would like to emphasize now for patients in the audience who have PBC.
Sure, I'll try to sort of address these questions together. So I would say that in terms of ursotherapy post-transplant, this is relatively new data that we've been given access to, and that has been published, that shows that patients who have had PBC should be put on urso post-transplant, right after transplant, because it does decrease the risk of recurrent disease and graft dysfunction post-transplant. So recurrent disease can happen in PBC. It's relatively uncommon, and it oftentimes does not associate with poor outcomes, but if we can do anything to decrease the risk of recurrent disease and bad outcomes, we will. And so everybody with PBC should get urso post-transplant. I talked a little bit about the outcomes, which are really excellent in patients with PBC. It is pretty uncommon to require a second transplant. I would say it's rare. That's not the same for other biliary diseases, but for PBC, patients do remarkably well. And briefly, life expectancy with stage 4 cirrhosis and PBC, it's really variable and dependent on the complications that can develop when you have cirrhosis. So if complications develop, like Kate was mentioning, fluid retention, bleeding through the bowels, confusion or disorientation, those things are associated with a worse prognosis over time. But there are many patients with PBC who can live with just compensated cirrhosis for years and do very well. And Kate told you a little bit about her story. When she was diagnosed, she had stage 3 to 4 fibrosis, and she did very well for a really long time. And that is pretty typical. It's just when the complications of liver disease develop that patients start to deteriorate clinically and require a transplant. distinguish between liver pain and right-sided pain from other issues. It's super hard. It's really, really hard, and it requires a good conversation with the clinician. It sometimes requires blood tests. It always requires a physical exam, but it sometimes requires blood tests and an imaging study to just make sure that there's nothing structural. But probably about 20% of patients with PBC can develop right upper quadrant discomfort. That doesn't mean their liver is not working. It's not more inflamed. It's not dysfunctional or anything like that. It's just a manifestation of disease.
Mm-hmm. Thank you, Dr. Ghulam Hussain. Those are all the questions that we have time for today. I would really like to thank our speakers, Dr. Aliya Ghulam Hussain, Kate Curvan, and Jackie Curvan for joining us. We have a regular webinar series, and these are our upcoming sessions. So on March 29th, we'll be having the second of our COVID vaccine Q&A for transplant recipients and for those pre-transplant, as well as living donors and others. You can register at Give Life UHN, or you can view it at Give Life UHN YouTube and register on Eventbrite. We also have another session on drug-induced hepatitis on April 15th. So please join us for those events. Thanks again to our speakers, and thank you to all of you for joining us today. See you next time.